Ladies and gentlemen, we're going to begin our program. If you could please take your seats. Wow, we got quiet quick. Holy moly, that's never happened before. All right. It really did. Good evening. Good evening. It's good enough. Hope you'll do better for Kevin and for the other speakers. My name is Eric Edelman. I'm the Executive Director of Kadima Mental Health Services. I'd like to thank you to the second annual Bright Nights event in partnership with the University of Michigan Depression Center. This year's program, as you know, is titled Understanding Depression. This important topic impacts many of us or our family members, including on both sides of my family. So I thank all of us for being here this evening. For those who don't know us well, Kadima provides comprehensive residential, clinical, and social services to all people with mental health challenges as they move forward in their lives. This year, we're actually creating a video commemorating our 35th anniversary. While we're still putting the final touches on the video, we do have a teaser that I thought we would share with you tonight. It's about 90 seconds, and I think it'll give you a much better snapshot of who we are and what we do. So we'll go ahead and play the video.
My name is Michael Basil. I've been a client of Kadima since 1998. I was really hyperactive that for some odd reason my mom couldn't handle me. But it was shortly after I graduated from high school when I came to Kadima. I went from a Kadima group home which was staffed for 24 hours to an independent setting. Kadima has referred me to job placing organizations and suggested that I go work at this new restaurant called Red Olive. I said, you know what, I can do this.
In 3 years, he has not even called up once, and he is some kind of guy who always takes his job seriously. If I could find another 5 more guys like him, I would definitely want to hire every single one of them.
Here at Kadima, we're about moving lives and moving forward. Mike abides by our mission statement here, and you can see his life is moving in a good direction.
You can clap. That's good. I don't know if you're clapping for the video or for Michael, who in addition to what you saw in this video, is a resident harmonica player, DJ, karaoke MC, and one of the leaders in our Zussman Activity Center. Michael really is an inspiration, and I'm proud to know him and the other 175 people served by Kadima who have equally important stories to tell. It's telling stories, it's sharing our experiences with mental health challenges, and creating more knowledge to help those suffering with mental illness heal. That's what's vital to our work. We're proud to partner with the University of Michigan Depression Center for the second year to host this Bright Nights event. We'd like to thank our partners at the U of M Depression Center, many of whom you'll meet in a moment. I'd also like to thank the JCC and the Berman Theater for hosting us this evening, thank our esteemed panelists who you'll meet later, and our sister agencies providing resources out here in the back of the room. I hope you'll please visit them on your way out. I'd like to thank the Kadima Board of Directors members in attendance, of which there are several. I'd like to thank you for all you do in supporting our work. And I'd like to send a special shout out to the significant numbers of our staff who are here with us this evening. I know I saw Yifat and Gail and Daryl and a number of others. I'd like to thank you very much for taking the time to be here. Two last staff people that I must thank, of course, are Michelle Malamas and Allison Huber from our development department who were responsible for today's event. So thank you, Allie and Michelle, and everybody else. Lastly, I'd like to thank the donors to the Tyler Howard Memorial Fund. The Tyler Howard Memorial Fund supported tonight's event. I'd like to thank its creators, Lisa and Jared Rothberger and Kathy and Michael Rothstein. The Tyler Howard Memorial Fund was created in response to the suicide of their dear friend, Tyler Howard, and we seek to provide education and suicide awareness. The Tyler Howard Memorial Mini Golf Classic fundraising event and super fun family-friendly event will happen again this September. Stay tuned for more details. So as we move on to our program, it's my pleasure to introduce Dr. Kevin Sethi from the University of Michigan Depression Center. Dr. Sethi is a psychiatrist at the University of Michigan, completing his medical residency this summer. He completed his ECT fellowship at U of M and is actively involved in the TMS clinic, and I'll let him explain all the acronyms. He's also completing his psychodynamic psychotherapy fellowship through the Michigan Psychoanalytic Institute. First one to say that 10 times fast gets 10 passes to the Tyler Howard Memorial Golf Classic. Ladies and gentlemen, please join me in welcoming Dr. Sethi.
Thank you for that introduction. Get situated here. Thanks for having me here tonight, guys. It's a pleasure. I'm hoping that this talk will help kind of just clarify some information about mental disorders in general, and we'll be focusing specifically on depression. Depression is a very complex illness. There's many facets to it, and so I won't be able to go over everything, but hopefully after tonight's presentation, you'll have some basic information about what it is, what are some of the treatments, and some of the new exciting innovations that are happening right now in the field, okay? So a few things I want to kind of go over are just what is depression, or some common features. Depression is actually very different for each person. Someone's depression might look very different, but there are some core features. So kind of want to go over what does that look like. We'll go over some facts and myths about depression. Some people, they have their own preconceptions what they think mental disorders are, what it isn't, and so hopefully through some of the information I'll go over, you guys will have a better sense what it really is. And then lastly, we'll talk about treatment options. Different things will be medications, neuromodulation, which is just a fancy word for brain stimulation. And it sounds kind of scarier than it is, so I'll hopefully help provide some information to you guys about that particularly. Different modalities of psychotherapy, cognitive behavioral therapy is what I'll be focusing on, and kind of mindfulness, but there's many different modalities of psychotherapy, so that's just a brief overview of those two that I find particularly helpful for a lot of patients and clients. And then kind of lifestyle modifications that we all can do to some sense, okay? So I'm not sure if we'll be able to answer this generally given the size of the audience, but if anyone's brave enough to kind of answer, I just want to kind of survey, how do you tell the difference between normal feelings and mental illness? Does anyone want to kind of be brave and give me an answer or response? Duration. Okay, could you tell me more? Okay. Okay, yeah, so she was saying duration. So if it's a response to a loss like grief or bereavement, then that's maybe a more normal, common reaction, whereas a depression would be something that's lasting kind of months or years. Any other, anyone else? Okay, yeah, so that's kind of pretty much it. So the difference between normal feelings and mental illness is really kind of functional deficits. If the severity of the symptoms are lasting weeks on end, months on end, and it's starting to impact your functioning, work, social interactions, kind of yourself, your safety, then definitely that's when we get concerned that the symptoms you're having might be a mental illness and not just kind of a quote-unquote normal feeling, whatever that might be to somebody, okay? And that's when seeking professional treatment and evaluation would be recommended if the duration, severity are going on and you're starting to notice this is beyond a kind of normal reaction. So if your normal feelings would be kind of if you're giving a presentation, if a loss happens, you're going to feel maybe anxious, you're going to feel sad, but it'll kind of pass. It'll wax and wane, and eventually kind of you'll return to your usual state. But if it's lasting beyond that, then that might be something more is at play. So what exactly is depression. So like I said earlier, depression is a really complex disorder. There's many different kind of presentations, so everyone's form of depression is going to be a little bit different, but these are some kind of few core symptoms that are shared amongst people that do have depression. One of the things will be kind of obviously a depressed or irritable mood. So it's not necessarily just being low and kind of sad all the time, but it could be someone who's more irritable, more anxious, having more tension. They're just not their usual kind of calm, relaxed self. They're always they're a little bit more agitated than usual. That could be a sign that this is not just kind of they're a little bit off, but it could be a sign that there might be depression. Difficulty sleeping, poor concentration, low energy. So these are things that are just, again, above and beyond your regular kind of fatigue or not being like quite your usual self, but it's really impacting your functioning. Mood swings, feeling worthlessness, social withdrawal, appetite loss, or gain, kind of you're gaining excessive weight, losing weight, that can be a big sign. And then kind of thoughts of suicide is the biggest kind of thing that we look at from a safety standpoint, where if that is present, then definitely seeking imminent treatment and evaluation is definitely going to be recommended. And so the bottom line, depression is a very severe form of mental illness. It's lasting typically a few weeks. 2 weeks is kind of the minimum we say, but if it's really severe, if it's less than that, then maybe it could be an underlying depression, okay? And it's going to have more functional impact. Oh, and the other thing I didn't say earlier, if you guys have any questions, there will be passing around note cards. So if you can just write that down on your note cards, we'll be collecting it later for the panel, and then we'll be answering them, okay? If there's any kind of general questions or specific questions that I'm talking about at this moment, feel free to kind of just raise your hand or kind of shout out. I'll try my best to answer. If not, then we can save it later for the Q&A, okay? So, like I mentioned, with depression, it's not uncommon that we have comorbid anxiety. So someone might just be very anxious all the time, a lot of tension, agitation. So that might not just be they're having an anxiety disorder, but it could also be represent there is depression. So there's a lot of comorbidity between depression and anxiety. Some of the things that you'll see with anxiety, kind of comorbid with depression, will be kind of excessive worry out of proportion to your stressors, physical sensation of kind of restlessness, inner tension, kind of feeling more sweaty, feeling kind of your heart's beating really fast, trouble concentrating again, kind of muscle tension, irritability. Is there any times where someone could think anxiety would actually be helpful or anxious feelings? He said when you're doing your taxes. Yep, that definitely could be a time where you're going to feel a bit anxious. Yeah, so it's going to be, so anxiety and kind of these kind of normal feelings are going to be healthy, common reactions that actually have a benefit. If, say, if something like a criminal or like someone was to come in here and like yell or shout, obviously our heart rates are going to be a little faster. We're going to be kind of sweating. We're going to be more hyper alert. That's actually going to be a good thing. We want to know what the hell's going on? Do I need to kind of care for myself? Am I in danger? But when you have like depression, kind of with comorbid anxiety, that kind of sense of dread, kind of hyper alert is going to be going nonstop, and that's where it's really going to start impacting you. So it's not necessarily a bad thing on one extreme, but if it's going on, it's super severe, then definitely it's going to start impacting you. So just some general facts about depression. It's the leading cause of disability between ages 15 and 44. And that's pretty impressive to me to think that it's the leading cause of disability for that age range. It's a huge kind of burden on our society and kind of our families, and so it's a very big thing. So I'm glad I'm here to have this talk with you guys to kind of reduce the stigma behind mental disorders and kind of let you know that there are treatment options and it's not something to kind of be embarrassed of or ashamed of. It's actually very common, as you can see kind of by that. 2/3 of people with depression actually don't seek treatment. And the sad thing is, a majority of people who if they did seek treatment, would actually show some benefit, okay? So about 80% of people actually show some sort of benefit to treatment, whether it's medications, psychotherapy, or other modalities of treatment, which we'll talk about a little bit later. There's actually a huge response rate for people. So people might think, oh, I wouldn't seek treatment, there's no point, what are they going to do for me? This is my life, I'm kind of used to it. But that's actually really not the case. So I hope that'll be a point you guys will take away. And the other big thing is suicide is the second leading cause of death between the age range of 15 and 44. I'll let you guys sit with that for a moment. That's yeah, exactly. And so this is a problem. Suicide rates have actually tripled since 1960. And it's probably going to, unfortunately, be still on the rise. So I'm hopeful the more talks we have, more awareness, especially for our adolescents, that's kind of where it starts. It doesn't just happen generally all of a sudden. There are things that have been developing. So the more that we're aware of this, know what's going on, hopefully we can kind of reduce this. And the last kind of factoid there is that there's a death by suicide every 12 minutes. That's how common this is. And the other thing too, depression in general, there's about 300 million people who suffer from depression worldwide. So that's how big it is. That's not the US, obviously, but worldwide. A few kind of myths about depression and kind of mental disorders in general is that depression is not a real medical problem. People might think, oh, it's just kind of in their head. It's, they could just get over it. But actually, no, the studies have shown that people with depression, the more they try to fight that negative feeling, just try to get over it, it actually worsens their depression. And the areas in their brain that kind of allow that connection between kind of thinking what's happening and their negative feelings, the more you try to push it out, the more it actually gets worse. So it's not really just in their head or kind of not controllable. It's a true illness. And that kind of ties in with depression being the lack of willpower. It's just false. Some people feel antidepressants might alter their personality. Again, another myth. Actually, most people report that when their depression is treated appropriately, they actually feel it return to their kind of baseline personality. They feel kind of back, like I'm getting back to the way things used to be. And if you're having any side effects, if you're having any issues, there's many different treatment options, medication options, and that could be discussed with your psychiatrist or physician that you're seeing. And then depression is always triggered by something. That's also another myth. It can happen, certainly, if you have a big stressor, a big loss, that certainly can trigger a depressive episode for somebody, but that's not necessarily always the case. So, and the reason why I want to include this is some people think, oh, if that person, they have everything's perfect for them, they have everything going, good job, good relationships, good friends, etc. They have everything. There's no way they can be depressed. That's actually really not true. There can be no trigger at all, and someone who has like a strong genetic basis or what have you, they might have a severe depression. So you can't always judge a book by its cover. And some of the biology of depression. So hopefully this will be a little bit more simple and not as complicated as this diagram makes it seem. But so some of the biology that we do know with depression is that some of our brain, areas of our brain, particularly the hippocampus, it's our kind of our memory center. It actually reduces in size, and kind of the regeneration rate of those neurons are actually decreased with someone who has a severely depressed episode. And they've actually shown when you've treated that depression, someone's back out of it, they've actually shown the regeneration of that part of the brain is actually back where it used to be. So that's, again, highlighting more of that biological basis of depression. And the other part, too, is the amygdala, that fear center that kind of makes us, is our alarm center, which is actually good, but if it's overactive, if you're always in a dreaded state, you're always paranoid, always feel negative, guilty about yourself, that's kind of overactive in depression. So that kind of explains a little bit of what's kind of going on. By no means is this the exact etiology or explanation of why people have depression, but these are some of the things that we do know. The other thing, depression, more from the kind of biological, kind of explaining what contributes to depression, is a neuroendocrine response, which kind of means our brain and our body's hormone system is kind of out of whack. It's always in a stress state where the brain is kind of releasing signals to the rest of the adrenal glands in particular, and you're releasing all this cortisol. Cortisol is our stress hormone. So when you're in a dangerous situation or something's happening, your cortisol levels are going to spike up. You're going to have that flight or flight response, and it's actually going to be positive. But if you're in a depressed state and this is kind of the state you're in 24/7, then obviously that's not going to be something you'd wish to anybody. And so those are some of the things that we can see, but we could measure labs and see if someone's cortisol level, which normally kind of goes down midday, if it's still pretty elevated, we can kind of tell how stressed, how severe things are going, and that does actually respond with medications. And I'll just add to that, for the cortisol levels, the data's kind of been mixed on the utility of it, but it is one of the things that can be helpful. So it's not the end-all be-all, but it is one facet. So regarding kind of treatment options, there's many, many different treatment options, and I'll be able to go over a few of them, but by no means will it be an exhaustive list. So the few basic kind of categories are based on the severity of someone's depression. So if you have kind of mild symptoms, it's the first episode, it's very reasonable to kind of, as the graph there indicates, is start with like psychotherapy or medications or both. Generally, some people might need just kind of psychotherapy alone to kind of deal with their symptoms and kind of just do better with that. Some people just might need medications based on their preferences or need, but most people, they actually benefit with both. And so if you're engaged in one modality of treatment, I think it's worthwhile to consider adding another modality if you're not having the full kind of benefit or kind of remission of your symptoms. Kind of as we go on and we move up along the severity of the depressive symptoms, there's different kind of modalities of treatment, which is actually pretty exciting because we have more ways of tackling depression in the past few years than we've had in the past 20 to 30 years. So some of the newer treatments are TMS, which stands for transcranial magnetic stimulation, which I'll talk a little bit about just to give you an overlay about what that is. And then ECT, which is traditionally referred to as shock therapy. Again, I'll kind of go in more detail about that. And then there's a vagal nerve stimulator and deep brain stimulation. That's something we won't be covering today, but other options. So medication options. Many people, like I said, are kind of afraid of medications, feel they're going to be taking a mind-altering substance and it's going to be kind of changing who they are or what they, their mind, their consciousness. That's actually really not the case, and kind of people do feel much better. They feel like their usual self when they are out of that depressive episode. We have a few different kind of classes of medications. There's actually a few more, but some basic ones. They work on the serotonin system, kind of norepinephrine, dopamine, are a few neurotransmitters that we kind of can increase their levels to help people with depression. And we do know that there is actually a really good response rate. If you look at this chart here, they did a good study several years ago that showed that the cumulative response rate was somewhere around 70%, and that's for remission rate. That means having no symptoms or returning back to your baseline level. And that does not even refer to the kind of response rate, which is maybe just having half your symptoms kind of improve. So having some clinical benefit is actually going to be even a bit higher than 70%. So medications are an effective tool that we have, but again, it's only one tool, and it might be enough for a good number of patients, but that doesn't necessarily mean that there's other modalities of the treatment, other things that should be considered, such as psychotherapy, lifestyle modifications, etc. And if there's any questions about different types of medications, treatments, side effects, kind of feel free to kind of write that down and we can go over it later on. So one of the new exciting things in the past week actually is about ketamine, more so the intranasal form of ketamine. So ketamine is actually a really interesting treatment that's pretty exciting right now. The jury is still out to kind of see the long-term benefits that we're going to see, and kind of it is being studied a little bit more extensively to see what are the long-term effects as well. But what we do know it's a very rapid treatment for depression. And when I say rapid, I'm referring to within hours or days. About 50% of people, they've done some studies with IV. So you can take ketamine IV intravenously, or you can take it intranasally. Through the intravenous ketamine, about 50% of people have had about a 50% reduction of symptoms within a few hours to a few days. So that's actually pretty impressive, whereas typically antidepressants can take several weeks, up to 8 to 10 weeks to have a full response, and that's at most therapeutic dose. So that's a big game changer. The downside, though, for the IV ketamine, they haven't shown kind of the long-term benefits. So when they've kind of looked at people at so the first week, a really good response rate, like I mentioned, but 2 weeks later, not as hot. It's kind of around maybe 11%, 20% rate. And so that's kind of with the protocols are still being determined. What's the optimal dosing strategies for ketamine? There is some good studies about kind of doing maintenance ketamine, and that means kind of like you do other treatments, it's kind of like, okay, once every week, 2 weeks, et cetera. And that's actually shown some promising data, but we're still trying to figure out what is the right dosing frequency for that and what's going on. And the exact mechanism, so I put up some information about that. I'm not sure if it'll mean much to everyone here, but it's an NMDA blocker and it also has some opioid activity, meaning opioids are kind of our pain receptors in the brain, and kind of by activating that and kind of by decreasing our excitatory transmitters in the brain. So when you have depression, one of the theories is that you're overly excited and you can kind of decrease some of the neuronal kind of regeneration. This helps kind of reset some of that and help build back some of those connections that were previously being hindered by the depressive episode. And so there's other actually mechanisms we don't fully even quite understand right now, and it's actively being researched. What exactly is ketamine doing? The interesting thing, so ketamine is actually a anesthetic initially, and it's been around for decades. So it's not a new treatment, but we're now finding that it's actually a new treatment for depression. And the interesting thing is the dose actually is we're trying to figure out what's the optimal dose. So when we give someone ketamine for sedation, we're kind of dosing at much higher rates, and they're knocked out, they're unconscious like we'd want them to be. But when we actually reduce the dose of ketamine, so they're not unconscious, they're not fully sedated, they might have like a dissociative altered experience for an hour or so, but they're fully aware, that actually has been shown to be the antidepressant effect. And that's kind of interesting. You'd think more would be better, but that's really not the case. And the timing of the ketamine is actually, the timing of the infusion has what's been also shown to be effective for treating depression. So if you were just kind of give someone an injection of ketamine and that would be their treatment, and would they have a good response, you'd think, yeah, probably. But no, it's actually when you slow down that infusion over 40 minutes or an hour, that's actually when it's shown to have antidepressant properties. So it's a really interesting drug. We're still learning a bit about it and how it affects for depression particularly, and what mechanism is at play for that. The thing, like I was talking about, is so ketamine, the intranasal form of ketamine was actually FDA approved this past week. So that's really exciting. It's not as efficacious as the intravenous IV ketamine, but does show actually pretty good response rates that are somewhat mixed. So the jury's out to be how will that be for long term when people are taking it on a larger basis than they've done in the studies. Okay, so any questions about that? Definitely we can talk more about that. So the other form of treatment is kind of TMS, transcranial magnetic stimulation. You might have seen some advertisements, heard about it on the news. It's actually been FDA approved since 2008, but it's now starting to get more traction as insurance and kind of people, the awareness of TMS is more than it used to be. So TMS is, we're generating a magnetic field. We're running a current through the magnet, and it's inducing an electromagnetic field that's stimulating one of the mood centers of our brain. The dorsolateral prefrontal cortex is what it's called, but that's not really important. It's one of the centers that have been shown to be implicated in kind of our emotional centers. And so by kind of stimulating that center, you're helping kind of stimulate some of the neurons and the pathways that were being hindered when someone's in a depressive episode. And so just some basics about TMS, transcranial magnetic stimulation. It's an outpatient procedure. There's no anesthesia, no sedation. You're fully awake the whole time you're there. You're in a pretty comfy chair. It's kind of like a dentist's office, or the chair's like a dental chair. But we're not pulling any teeth. And so the sessions last between 25 to kind of 40 minutes, and you're having it's like a woodpecker stimulation on your head where it's the site that we're stimulating. And the sessions are about 6 weeks where you're having about 25 to 30 courses. And then so when do we consider TMS for patients? It's generally not the first line of treatment, although there's some controversy on when you should kind of consider more aggressive strategies, but it's generally after someone has about at least two antidepressant trials. At times can be up to 4 to like 6 more trials. So at least 2 is the kind of bare minimum, I would say. And so that's when we would consider TMS. And the response rate is pretty good. It's at 58%. So response means like about a 50% reduction in symptoms. And then the remission rate is at 37%. And that's through some data that they've collected since TMS has been more widely studied and completed amongst patients. So overall, that might not look too impressive for people. It's actually pretty good from a mental health standpoint. And then the other thing I want to talk about is electroconvulsive therapy, also known as shock therapy. So there's definitely a lot of stigma about that based on movies and kind of what we've seen in the media. And hopefully, by giving some information, I'll help kind of clarify some of that and demystify it. So it's actually our most effective antidepressant treatment with remission rates, and that's remission rates, meaning symptoms are at very low levels, between 60 to 90% based on the type of depression, kind of what's going on. So that's a pretty impressive fact. Like I mentioned, TMS was around 40% remission. This is between 60 to 90. So it's pretty impressive. It's safe during pregnancy, so I think that speaks for itself. And so with electroconvulsive therapy, what we're doing is we are providing a small current that's activating the entire brain, and we're inducing a controlled seizure where you're under anesthesia, you're in the hospital. It can be done as an inpatient or outpatient procedure, and then you're sedated for about 5 to 10 minutes, and the seizure is fairly brief, between about a minute or so, and then kind of once the seizure is completed, you're in a recovery area for a few hours, and then you're either home, or if you're in the hospital, then you'd kind of go back to your original kind of location. And so your muscles are kind of relaxed, so you're not kind of flailing or kind of potentially kind of hurting yourself, but you're actually just kind of tensing up. It's kind of like a very intense workout that you're having without having to work out. So you might feel a little bit sore afterwards. And you could have some kind of short-term confusion. Memory is like kind of the big thing, but that generally does clear up a few weeks after. So it's one of, ECT is one of our most effective forms of treatment for depression, and it's also should be sometimes considered if there's really severe things going on, if someone's pregnant, or if there's other factors. So I want to talk a little bit about psychotherapy. There's, again, like I said before, there's many modalities of psychotherapy. The one I'll be talking about is cognitive behavioral therapy because it has one of the most evidence bases for it. And so kind of what is cognitive behavioral therapy? So the theory of cognitive behavioral therapy, one of the premises is that when you don't usually just have a negative emotion, right? You don't just kind of feel depressed. You don't just feel anxious all of a sudden. There's usually actually some thought that's underlying that emotion. And so it's kind of trying to recognize, okay, so what thoughts am I having actually? Because you have a thought that actually leads to the emotion of feelings of depression, guilt, what have you. So it's trying to better understand, what is that thought that you're having? Does that thought make full sense? So if you're having a thought like, I'm a bad person, no one cares for me, I've done all these bad things, or everyone's looking at me, everyone's judging me, what are those thoughts you're having? And that leads to an emotion. So CBT is trying to see, what are those thoughts? Are they based in reality or not? And so how are you perceiving the world? If it's kind of like if you had a pink lens on. If I had a pink lens on right now, everything I would see would be pink. You'd be wearing a pink shirt, you'd be wearing a pink coat, and then you guys would be like, Dr. Sethi, what the hell is wrong with you? She's wearing, a red vest, he's wearing a black coat. It's because you got these crazy pink lenses on. I'm like, okay, so I take that off, and then I realize, oh, that's actually a red vest, that's a black sweater. That's kind of the same thing with cognitive behavioral therapy. When you have these negative ways that you're seeing the world, we have negative thinking patterns, then you're going to view everything in a negative manner. So the thoughts that you're having might not make the most sense. And so by looking at seeing what are the negative thinking patterns I'm doing, you can better recognize what is a more rational, evidence-based kind of thought. So it's not trying to make up a fictional kind of what you want it to be, like I'm the best person, I'm the strongest person, etc. No, it's trying to say, maybe everyone doesn't hate me, maybe I've done these things, these are bad, these are good, and, so it's somewhere in between. So that's kind of a brief premise of kind of CBT. It's trying to reshape that negative kind of thinking pattern that's going on. And the other part of the CBT, so cognitive behavioral therapy, is the behavior. I believe that's the doing part, right? So it's kind of, if you have a certain negative mood, if you're feeling really depressed, you might, you'd probably isolate. You probably, won't go out, do what you normally do. You might kind of be more irritable, might argumentative with somebody. So it's trying to recognize what are some of the patterns of behavior that you're doing that are contributing to that cycle. And then at times you can try to kind of break that, either the thought pattern or kind of the behavioral pattern, if that makes sense. So by doing certain things, sometimes we get that myth where we feel like if I just feel a little bit better, if my mood's better, then maybe I can go out, maybe I can go out with my friend, maybe I can do this activity. But it's actually kind of the other way. It's like you have to do that thing that you normally like, that in turn is actually going to make you feel a bit better. And so these kind of concepts can be pretty easy, pretty basic. Oh yeah, I get it. But actually the practice of it is very difficult. And that's where working with a therapist, working with your psychiatrist is going to be instrumental. And so kind of what is mindfulness? Mindfulness is kind of an element of different modalities of therapy. It can be with CBT, another modality of therapy, dialectical behavioral therapy. But basically, mindfulness is trying to pay full attention to something, trying to be focused on the here and now in the exact moment. It's not uncommon that we often are. Our minds are kind of scatterbrained. We're thinking about 100 different things at times. We're on our cell phone. We're kind of driving, texting, looking at what we're going to cook for dinner, and then trying to make it somewhere in 5 minutes. Of course, when you do that, bad things are bound to happen. So kind of mindfulness is trying to slow down that kind of that chaotic brain, that mind that we tend to kind of, the environment fosters a bit. And so the being mindful is the exact opposite of rushing, of multitasking. It's just trying to be in the present moment right now. And so when you're mindful, you're taking your time, you're focusing in a relaxed way, and mindfulness exercises are actually very simple, can be, a few minutes, could be longer than that. And so some basic mindfulness exercises would be kind of focused on breathing, kind of on the present, your current emotional state, and kind of trying to recognize how you're feeling. It's not uncommon where people get in kind of an anxious state, a depressed state, where they don't even know what's going on. They don't even tell themselves, how am I feeling? And they're just kind of in autopilot. So this is trying to put the brakes on that. So why do I kind of talk so much about mindfulness? It's because there's actually a lot of kind of research and data behind mindfulness that supports its kind of implementation. As you can see kind of from that picture on the left side there, is that the brain is super active before implementing a mindfulness exercise, and then kind of later on you see much kind of more blue, more green, as opposed to all the red. So literally the brain is kind of shutting down, it's calming down. So not only do you subjectively feel a bit better, your brain is actually responding as well. So it's a very powerful tool. Even though it seems relatively simple, pretty easy, it's very powerful. And there's actually a good app I would recommend. It's called Headspace. It walks you through different mindfulness exercises, and that can be kind of that when you're feeling stressed or things are kind of overwhelming, that could be a good way to kind of help bring yourself back to your baseline. And then just some general lifestyle modifications that are very effective for treating depression and kind of general well-being, mental health well-being. Is kind of healthy eating. So kind of studies have shown that the more if your diet's based on kind of Big Macs and fries and Cheetos, you're going to kind of generally feel more sluggish, and you're actually going to be kind of in a lower kind of mindset than you normally would be. And that kind of makes sense a little bit too, because depression is actually, some forms of depression are actually an inflammatory process. So you're in a more active kind of inflammatory state, and so definitely the foods we have a contribution to that. Other things that are kind of basic lifestyle things that can be very helpful are actually physical exercise. So daily activity, kind of walking, running, kind of getting your heart rate up a bit, not only is good for your general physical health, but also for your general mental health. Proper sleep and hygiene, sleep hygiene. So, of course that makes sense. If you're not sleeping well, if I'm not sleeping well, you're going to feel like crap the next day, and if that's going on for weeks on end, definitely it's going to play a toll on you. So kind of trying to work on your sleep behaviors. So sleep hygiene is kind of your behaviors. It's not, I had one time a patient come up to me who had horrible sleep, horrible depression. I asked her kind of what's going on. She would tell me regarding her sleep, oh, I'd have coffee at like 8 p.m. Well, I told her, well, that's something we got to fix. And a few weeks later, she came back. Dr. Sethi, yep, I changed that. I'm not drinking coffee anymore. It's more like 4 p.m., not 8 p.m. How's your sleep doing? Much better. How's your mood doing? Much better. So definitely kind of our sleep hygiene, how we're, acting kind of in the evening time before we sleep is very important. Positive relationships and kind of stress management. So kind of just trying to be more social, having more of a support network. So if you're feeling particularly down, if you know things are stressful, it's not a bad idea to kind of reach out for help, let someone know, or maybe you don't need to share everything, but to say, hey, this is usually a good thing for me. Let me go be more active and kind of reach out with my support network. And then kind of stress management is like kind of doing things that you'd like to do that are kind of soothing. So kind of just some key takeaways that I hope you guys got from this is that depression is a medical illness. There's many kind of facets to it from a psychological, social, biological standpoint, but definitely it's not something that someone's faking or wants to be. It is a true illness. There's many different treatment options. So if, whatever you pursue, if it's not working, there's many other options. So by no means have you exhausted any of your, all the options. There's definitely a lot of resources and help, and hopefully as we have more awareness and more talks and resources, that'll make it easier. And then early treatment is definitely going to help reduce the severity of the overall course in the illness, the prognosis. The longer someone is in a depressive state or having any other mental disorder, the harder it is to treat, the harder is it to kind of get better. So definitely if you're having symptoms going on for a few weeks, definitely I would seek advice sooner than later. That's going to yield a better success rate. And the Q&A, so if you guys have any questions, please write them down and we'll be answering them shortly. And with that, I am done. I'd like to bring up Eric, I think.
Give a hand to Dr. Sethi, please. I would like to invite the panelists to please come on up. All right, just give them a moment to get up. There's people collecting the cards. If you have some questions, please, if you have questions on a card, raise your hand and somebody will come and get them from you. Thank you very much. Let's have the panelists go down. We'll have them just introduce yourselves. You can say who you are and why you think you find yourself here today. We'd appreciate that. So we'll start with Jean.
Hi, I'm Jean Nemenzik, and I am the Director of Clinical and Residential Services at Kadima. So that's why I'm here tonight. Go ahead.
Hi, I'm Dr. Harry Rai. I'm also a co-resident of Dr. Sethi's. Besides being his close friend, that's not the main reason I'm here. But I'm also here because I enjoy giving these public talks. I've given talks at Kevin's Song and several other Bright Nights. So just enjoy this interface with the public as opposed to always in the office.
Kevin Sethi. I'm just here for the food.
My name is Corbin Stanley. I am a board member and secretary for the Michigan chapter of the American Foundation for Suicide Prevention. I'm also a doctoral student at Michigan State, but I come in peace.
Hi, I'm Mike Bawadi. I'm the director of NAMI, National Alliance on Mental Illness, for both the state level as well as NAMI Metro, which is a local affiliate.
I'm Ren Bollier-Hack. I am listed as community member very proud. I am the mother of 2 children who struggle with mental health and the wife of a husband who also struggles with depression.
Thank you very much. I'd like to give a hand quickly to our panelists for being here with us today, which also gives me another second to organize the cards. We have a number of questions. We're certainly not going to be able to get to all of them, but I'd like to thank you for taking the time to write some questions out. There are a number of questions, thank you very much, a number of questions about this topic. So if you would just, if you want to address this, any thoughts on approaching depressed individuals who may be withdrawn or uncommunicative? I think there are several questions about what do you do if you know someone in your life is suffering from depression? What should you do?
So I think that sometimes the most helpful thing we can do is ask what we can do to help. I think probably one of the worst things we can do is, aside from ignoring it, is making assumptions about what's going to be helpful. I think, you know, if it's someone you care about, you need to approach them from a standpoint of care and concern. I think it's always really helpful if we can tell people what we're seeing that is concerning to us so that they understand why we're coming to them with this. But that's generally what I do.
No, I totally echo that as well. And I guess just to add to that, one other thing would be trying to do as much from a place of non-judgmentalness as possible. You know, even myself being a psychiatrist working in mental health, even myself, I find myself having stigma against the illnesses that I treat. So I can only imagine being someone that doesn't even have the professional insight I have, how much stigma there is out there. And people pick up on it. People do pick up on it. So if there's any sense that you're really, you know, and somehow shaming them for what issue that they have, they will react to that. So just trying to really get to a place of non-judgmentalness, I think, is always helpful for most things.
Any other thoughts?
Something I would add is that to address the person with loving care, but to also understand if they are depressed, as my husband explains it, it becomes a new reality. They aren't necessarily aware of it, and they need to be made aware of it, and need to be made aware that their behavior has changed, their thought patterns have changed, and sometimes you need to step in a rather direct manner to be able to jar their mind to understand that things are not as they have been, and that different treatment needs to be sought.
On that same card, or one of those same cards, and I'll put you on the spot here, Dr. Sethi, somebody asked if we get a copy of your slides. Any chance you can make those available to us?
Sure, yeah.
Wonderful. So we'll hook up with Ali or Michelle afterwards. We'll either post them on our website or email them out if people emailed when you or gave us an email when you registered, or otherwise available at the Kadima office. Thank you. A couple questions on this. I'm going to put a few together. Could you talk about what to do if a particular person is suffering from both depression and either an addiction disorder, or with depression and some other significant physical illness that may be linked? Can you talk about how to work with somebody who's dealing with both of those things? How can do they have to address both of them? Do you address one or the other when they're kind of a package deal? How do you manage that for some folks?
So I think that's hard to specifically answer just because there's so many different kind of nuances with each person's case, but generally having kind of comorbid physical or other kind of mental disorders is not the exceptions. Actually, it's very common. And so dealing with like substance use disorders or an addiction and the comorbid kind of mood disorder, depression, what have you, is actually commonly done, and there's a lot of dual diagnosis treatment programs out there. So I think kind of trying to tackle both issues at the same time is what I would recommend. But obviously, if one is more pressing, one is causing more imminent harm, such as like an alcohol addiction or another kind of substance addiction, that might be needed to be addressed first before additional kind of treatment for the underlying depression, let's say, could be treated.
Any other thoughts?
I would just add that sometimes you have to prioritize. If you have an addiction and a mental illness, you need to deal with the addiction first, then the illness. It's kind of go after what you can, but you also have to go after what is in the way of being able to dress appropriately. the illness?
Yeah, mental illness is you're not going to be solving it with a pill, or it's not a single line. You have to be in recovery, and most people that suffer from a mental illness are in recovery for the rest of their lives. Unlike maybe other illnesses such as cancer or diabetes, some people can be cured from that. But it has to be understood by the individual that, they need to deal with, if it's a comorbid situation, they'll need to deal with, obviously, if it's an addiction, deal with the addiction first, I think, and then deal with, of course, the mental illness, because the addiction can be taken, it can be solved. That's one thing to note. And then once that issue is out of your life, then the recovery from mental illness can begin.
Any other thoughts?
So I would take a slightly different point of view on this, respectfully. I think, I don't know as a clinician whether or not I think one has to be addressed before the other. I think, as people have said, it really depends on what's causing the biggest effect in someone's life, what brings them through the door. I think the most important thing to know is you can't treat anything in isolation. Everything, it kind of relates back to each other, and everything, it has to be addressed concurrently. And in the last 20 years or so, I think we've really kind of, in mental health in this country, adapted or tried to adapt. We at least have a philosophy of a no wrong door kind of approach. So if you're looking for mental health treatment, you should be able to find treatment for your substance abuse. When I first started working as a social worker, there was a sort of idea that if somebody came to a session and they were under the influence of drugs or alcohol, you couldn't see them for their mental health problem. And sort of over time, we began to realize that doesn't make a lot of sense. That's like if somebody goes to their oncologist and they're nauseous because of their chemotherapy. Well, I can't see you till you take care of your nausea. I mean, it doesn't make sense. So I think we just have to not try to treat these things in isolation.
And just to add to that, there's a case that came to mind with that question. So I have a young guy. I'm pretty sure I protect his privacy. He's a young guy, college kid, and smoking marijuana every day. As I'm sure people in this room can relate, it's becoming much more common. And the approach that I took with him was that he had a severe depression. He also has OCD. So my goal with him was to build a rapport with him, make sure we treated the depression, the OCD, those both got under control. And then when I had that strong rapport with him, I was able to bring up the marijuana in a way that was not judgmental, to a way that he didn't find offensive, that he didn't react negatively to. So I think that I guess for me, I would say there's different ways to get at it. And sometimes building that connection with someone treating the underlying disorder helps them see where their addiction is as well.
One last thing, I just would say that the number one thing overall would be to get to a diagnosis, because a lot of people that are slipping through the cracks today in the mental illness and mental health crisis right now are going out saying they don't really know what they have. Do they actually have a mental illness? Is it really, are they in crisis? Is just this an abnormality, for example? They don't know really where to go for help. I go to a lot of colleges, a lot of high schools, and one of the questions I ask is, by the raise of hands, who knows somebody who is suffering from mental illness or mental health issues? And obviously this room is biased, I can't do that here. But I honestly, when I go to colleges and I ask that question, there's not one hand that's not risen. I mean, every hand is up. And that tells me, obviously, that they know people. They don't know really what to do about it, and that's why, obviously, they're there, or maybe it's the teachers that are making them show up. But the issue is they really don't understand what a diagnosis is. And a lot of people, when we're finished presenting, they come up and said, this has helped me enough to say I'm strong enough now to go and get a diagnosis from an actual doctor. Because before this, they were just sort of playing. They were kind of playing it out, right? They're kind of saying, well, what do you think I have, to their friends? Or, they might just go to somebody who doesn't have the ability to diagnose what they have. And again, they have combinations of, they could be anything, right? Drugs, or they could have any mixture of things that could be comorbid and whatever, that could that could be obviously cured or solved, right? And but they really need to understand what they have before they can fix themselves.
Any other comments? Some good discussion on that question. I appreciate that. This question may be in particular for you, Dr. Sethi, though anyone else should feel free to respond. There were a few questions both about ketamine and TMS that I wonder if you can answer. Lots of questions about side effects of both, if you could speak to that. And there was also a question about any impact on memory with TMS or any contraindications for it. So if you could speak to those questions generally, please.
Yeah,
or
so-
anybody else.
So TMS is actually relatively very safe. The main side effects are actually kind of the pain at the stimulation site. So I kind of describe to patients, it's like kind of like a woodpecker's tapping on you, even though physically nothing's on touching you per se, besides the kind of the TMS device. But the magnetic field is kind of stimulating you, so you'll feel kind of that pain. But that actually kind of gets better over the course of the treatment. So where someone might initially have like an 8 out of 10, 7 out of 10 pain, it generally goes down like a 3 out of 10, 2 out of 10, what have you for people. So that's kind of the biggest side effect, is that pain, and that's the most common side effect. Other side effects could be headaches or some muscle tension, and that's actually relatively easily treated with kind of Tylenol or Motrin before for the treatment session. In terms of memory side effects, no really memory side effects with TMS. You're not sedated, you're not, there's no anesthesia or anything. You kind of come in the office for about 40 minutes, and then you're on your way for the rest of your day. So there's really no big sedation. The biggest contraindication would be if there's like an ongoing, like any kind of brain disease or something recent that's going on. That might be a relative contraindication, or someone has like ongoing like recent medication changes or seizure. So seizure is like there's a small chance, like 1 out of 10,000 of inducing a seizure. So that's kind of something I let people know, but we haven't had any at U of M, and they've done a good number of treatments. And I think the other one's about ketamine.
Yeah, same question.
So ketamine, no, in terms of contraindications, like an absolute contraindication, none that I can think of, besides if there's some active medical things that are going on that are recent. But otherwise, if you're generally healthy from a physical sense and just suffering with kind of depression, refractory depression, no big contraindications from that standpoint. The main side effects people might experience are kind of a dissociative episode, might feel kind of a little bit woozy or have like a headache. That does generally get better. We do monitor your vitals and your blood pressure. That's something that can go up for some people. We just kind of slow down the infusion and then kind of resume, and they usually do better. So relatively well tolerated.
Though I guess the only side effect I would add to that, there is some theoretical risk of abuse with ketamine. I mean, it is a party drug at much, much higher doses. So we're still trying to work around where exactly that risk is. You know, honestly, I've been reading about it over the past week after I got approved, so we're learning ourselves.
Any other comments?
So I would just, and I would of course invite you, the doctors to add anything to this or disagree if you disagree, but I think my own bias as someone who does psychotherapy is to want to say that while all of these treatments, going back to the ECT, to the electroconvulsive shock therapy, are most useful in preparing the brain to be able to take part in psychotherapy. Actually, that's really one of the big benefits of medication, is it gets the brain ready to be able to learn and to make changes. So all of these treatments, I think, can help a lot and can have profound effects on the way the brain functions, but none of them are magic bullets, for lack of a better term. But they are, I think, key to being, because a lot of times people will come into psychotherapy in a state where they really can't absorb any new knowledge, they can't learn new skills, they can't gain any real insight.
No, I actually personally totally echo that. You know, I plan to actually do dual psychotherapy medications and interventions in my practice for that exact reason, because I feel like it works the best, and the data supports it. You know, actually, I think you showed it for was the STAR-D, right? Yeah, so he showed it from one of the largest antidepressant trials. That same trial also showed that the combination of psychotherapy and medications was the most effective. Even like at a basic science level, they show that when you have people on SSRIs in particular, when you have higher levels of serotonin, that actually allows you to grow new neurons more easily. So they've shown that in petri dishes, so you can only imagine what it does in the brain too.
Go ahead, please.
I'll just add, so with different modalities of psychotherapy, you actually do have biological changes too that you're triggering with your kind of your different connections in the brain. So it's a very kind of powerful tool, and I just echo what's been said so far. So it's kind of like training a muscle, you're training your brain, and so when you're feeling better, it makes sense that you're gonna have kind of changes in your brain. So yeah.
It's always nice when the panelists lead into the segue to the next question. So thank you very much. The question is, and I'm going to just read this directly. It says, what to do if a teenager is depressed, is taking medication, but refuses counseling? This particular teenager has major depression and did try a suicide attempt 2 years ago. And so there's somebody here wondering what to do in the case where they're willing to take the medication but not engage in meaningful counseling. So can you talk about the thoughts on what to do in an instance like that?
I mean, that's the most challenging situation of all. I mean, we come up against it all the time. I mean, I think there's many approaches. I guess the first that leaps to my mind, partly it's kind of my bias, my approach with patients is to really go at it from a non-judgmental perspective, to try to understand why they don't want to go to psychotherapy. Do they not believe that it helps? Did they have a really bad experience in the past that's colored their perception of what psychotherapy is? I've actually just spent more time thinking about it. I feel like sometimes it's easy to look at people and they make a bad decision and you're like, oh, why don't you just go to therapy? Sometimes people have good reasons for doing incorrect things. So I guess that's one of my pieces there. Another thing that popped in my head is that a lot of people don't like the idea of sitting one-on-one with a therapist. It's kind of intimidating for them. They kind of feel like they tell their whole life story. And sometimes in those things, I think group therapy, it can be very helpful as a way to get them in the door, particularly teenagers and young people.
So I'm going to put in a shameless plug for the Creative Expressions program right now that we're doing at Kadima. We've introduced a lot of art activities, and art therapy has long been an alternative means of psychotherapy that gives people a different way of expressing emotion and telling a story. And that's kind of a fascinating thing for us. And at Kadima, we've been doing music therapy, we've been doing art therapy, visual art therapy, we've been doing some movement therapy, and it's really quite inspiring. There's a lot of different ways to get at this.
Any other thoughts?
I'll give a, go ahead.
Oh, thanks. Regarding suicide specifically, I know they mentioned the teen had attempted suicide. I would make sure to have a safety plan in place with regard to suicide attempts. We do have some information, again, I'll also do a shameless plug, on our table in the back about safety planning and lethal means reduction and those sorts of things. Research shows that those who attempt suicide are significantly more likely to attempt again in the future, so that's definitely something that's sort of immediate and should be handled immediately in terms of safety planning. Then I would just echo what they said. I think that group therapy approach is a really good way to get the foot in the door. That's definitely a good approach.
I was just going to say, as a parent of what were at one time a teen who took their medication and refused therapy, sometimes you don't have a choice. You have to sit with it. My daughter specifically, who was diagnosed with bipolar at 9, went through numerous therapists, some good match, some not, and she got to the point that she was done. It doesn't, you can do all that you can do as a parent, as a supporter, as a friend, but they're going to make a decision. And luckily for my daughter, she has at different times, she's now in her 20s, has chosen to go back into therapy, but more often than not, she's not in therapy. And thankfully, she takes the medication. There were times that she wouldn't take that either. So at times you just got to be grateful for what you can get. My son, unfortunately, has been diagnosed, and he's 20 and won't take medication or therapy. So while I so respect and appreciate the medical viewpoint, at times on the ground it looks very different, and sadly so. And I think that's important to note.
Yeah. I think there's a huge need for patience with this stuff. And being able to sometimes wait out the situation with people. A close friend of mine who struggles with depression told me something that was so, I never thought about it this way. He said, it's one of the only parts of the body that when it's broken, you have to use it to recover. You know, you break your leg, you get to rest. You don't walk on your broken leg. But when your brain is sick, you have to use your brain to work your way out of it. And that's a challenge. That's huge.
Michael, do you have something you were going to say?
Yeah, I don't have any shame, so I'm just going to go out and tell you that.
Plug away. You're all
I'm,
on the
I'm,
panel.
I'm
You're all in the back.
plugging.
We're gonna plug.
I'm just going to let you know that I feel for the people in this room because you are the caregivers of the people that are obviously needing help. And all I can say is, you need a lot of support. The references that Dr. Sethi had said and the things that are up on the screen regarding references, they're there. They're all in the back, It's really, really tough to make a proactive treatment plan for your loved one. But in the end, that's what you have to do. Because to be honest with you, I'll tell you my own personal story very quickly. I was in a room with Dr. Sethi one day, and I was expecting a prescription pad come out of the doctor's coat, and he was going to write a script for me for a pill that was going to take away everything about mental illness. And to be honest with you, he did take it out. He did sign it, but there was nothing on that pad. He goes, Mike, you're going to have to go out there and be proactive and be accountable and learn as much as possible about the illness. Which is why I'm coming to you to tell you as a caregiver, you're going to have to do that. You're going to have to go to many more of these meetings. You're going to have to go and learn as much as you can, whether it's, again, the scientific side or the psychiatry side or the psychologist side. You're going to have to learn as much as you can in order to support, again, your loved one. NAMI Metro does have a 10-week course just for you, not for your loved one, but for you. Dealing with recovery, dealing with the idea of how to take care of somebody, how to change, hopefully, their mindset to, again, that they will actually take medications or go into some sort of therapy or whatever. But it's for the people that are actually sitting out here in this area, this auditorium, that this is for you folks so that you get the strength to be able to go back and again, hopefully give some hope to your loved one. So again, there is hope is, of course, what we're all here for, but there are ways to be very proactive and accountable that, again, it's going to be up to the individual and yourself to help and do.
Thank you. We only have time for a couple of more questions. We had many more than we're able to get to, so you'll yeah. If you would, we can just, Allie, if you come just bring a pen over here, that'd be great, if you don't mind. She'll be over there with 1 second. One of the questions we have is, I'm afraid to discontinue antidepressants. Is it okay to take them for the rest of my life? So somebody would address that.
So, again, I don't know if I could specifically answer that. It really depends case by case, what's going on, severity of illness, the course, etc. But definitely I would kind of speak with your treating physician who's prescribing it. And in terms of being afraid to discontinue, it depends what's been going on. If you've been on it for years and are doing relatively well, really stable, engaged in psychotherapy, things are going well, have a good support system, then it might be reasonable, but it really depends on your individual kind of your story, kind of what's been going on. So I can't answer that. Some people who have with minimal symptoms, it might be safe, and it could be, and it'll be fine. If it's really severe, then it's, some people are on indefinite medication therapy. And so there's no long-term side effects that we do know that are kind of detrimental. So from a safety standpoint, I don't see any contraindication.
But you would probably recommend that that anybody discontinues any medication under the supervision of the doctor who prescribed it.
Yes.
Right.
Yeah, it really depends on also the diagnosis as well, I guess,
Sure.
what Kevin said.
Speaking of medication and looking to the future, maybe it's the present, but looking to the future, there's a question if there about the frustration some folks have with getting the right prescription or the right cocktail of prescriptions. And the question is where are we in terms of genetic testing to help identify the proper medication for somebody? It looks like I got a couple smiles, so maybe there's some kind of answer for that question. Let's see.
So it's I think it's actually pretty controversial right now, actually. So there's a group of companies that are doing genetic testing for liver enzyme activity, and they basically can detect whether or not you're a rapid or slow metabolizer based on those enzymes. And then they do a best guess of which medications are most metabolized by those enzymes. And that is supposed to roughly somehow give us a sense of which medications are going to be safe, which ones are going to be are going to have more side effects. But the data on that is not there yet. So there's a lot of movement towards a lot of people wanting these testing, but I actually have not read any convincing data that says it changes outcomes, changes what we actually do in psychiatry. It's like an $1,000 something test that a lot of people end up paying for out of pocket because their insurance won't cover it.
Yeah, I would agree with Dr. Rai. We just don't have the long-term data about it. I think it's promising and it's exciting. Definitely, I'm glad we're kind of thinking outside the box in terms of trying to personalize medicine, but I'm not sure we're there quite yet. And maybe there's some individual cases where it could be helpful, but from a large-scale perspective, we just don't have the data to support it at this time.
The census from the audience is to get going. Let's get that now. Any final thoughts from anybody in the panel? Things that you'd wanted to say today or points you wanted to get across? Anything you want to clarify that anybody said? Does anybody have any final thoughts? Anything they'd like to share?
There was a lady out here that had a question that she could probably ask.
Yeah, I do. It's kind of a comment. We speak in here about caregivers and various things. I'm a mentally ill woman that is 63 years old, that has tried everything and bipolar. And lately, the last 6 months was the worst 6 months that I've ever had. I went through a lot of things and I tried everything. But the one thing that I want to comment on, because I don't hear it enough, is that I am well, first of all, I'm quite a high-functioning person. I live alone with a cat. I take care of all my needs. Nobody in my family is really involved with my illness. I do everything for myself. But I cannot find groups for me. There is a huge gap in Oakland County for high-functioning people to get support groups, and I think that's something that needs to be looked at.
Can I comment? My son, who is 34, falls into her exact bracket, and it is a hole that is there. They go in front of people, and I compliment you, high, capability, but obviously that is not what exists.
Well, I kind
So-
of finished what I was going to say.
Briefly, please.
One of the major things about being mentally ill is the loneliness that you encounter. I've lost so many friends that don't want to be friends with me anymore because of my illness. And sometimes I don't even do anything. They just don't want to be friends with me. And we need groups out there. I would be even willing to help work on it. I live in Southfield. I'm a licensed. I was a social worker for many years. But it's really a terrible, terrible thing. I've called everywhere to try to get help for this. And there is nothing available.
So I'd like to thank both of you for speaking up. I'm going to encourage both, first of all, either or both of you come and get either mine or Jean's card later. Visit the Kadima booth in the back. We actually have programs exactly like what you're talking about. And I know a number of our colleagues in the back have those resources as well. So please take a moment to visit them. I'll give you my card, either of you or both of you my card personally. You're welcome to reach out and we'll tell you about what, because we do. We have programming groups for people in the age brackets you were just talking about, and very open to creating more. So please come find either one of us or the folks at the back at any of the resource tables. I don't speak for the programs of our other agencies, but I know a lot of them are concerned about this as well. So please come find us. Happy to give you a card after. So thank you very much for your question and for speaking up. Yeah. We can talk about that. Any other final thoughts from the group, if there are any? Then I will add my final thoughts as we wrap up this evening. Of course, the first and, I don't know about most important, but the first and an important thank you is to thank all of our panelists, so please a hand for all of them. We appreciate your time and your insights and for being with us here today and sharing your stories. Some of them may have to run and go, but for some of us may be hanging out for a little while. If there are some other questions or things you'd like to address, please come and find us. Of course, we'd like to thank all of the other presenters, all of our agencies in the resource area, of course, the folks who fund, the Tyler Howard Memorial Fund that supported this event. Want to thank our partners at the U of M Depression Center. And lastly, please visit the partners in the back and grab a cookie created by Kadima's Cookie Project by some of the folks that we serve. And two events that I want to just put in your mind. The first, somebody mentioned social media or something a little while ago. There was a next Tuesday, a week from what's today? I don't even know. A week from next Tuesday, the Jewish Federation and other agencies are hosting a screening of the film Like at the Maple Theater. There's only a handful of tickets left, but it's talking about the significant impact of social media on all of us, absolutely related to this conversation today. So feel free to check that program out. And Kadima's Gardening Day will be at the beginning of June. If you want to help beautify some of our homes, that's our next event. You can grab some information in the back. Thank you very much for taking time out of your schedule to learn about this important topic. Have a great night and drive safe.